we are going to have a debate about whether or not diagnosis is a good thing. And we're going to have a vote at the end of it. Just to get, because I'll let them explain. Anyway, we have Dr. Walden from King's Lynn, our newest consultant, and Dr. Jones from the Norwich. And Dr. Jones has been with the Trust for some time, and he's standing as prospective parliamentary candidate for Broadland this next year, what it will be. So Dr. Walden is debating on the benefits of diagnosis, and Dr. Jones is debating about the advantages of not giving people a diagnosis. Who would like to start?
Okay, thanks, Howard. Tell me if you can't hear me. If you don't, if the people at the back aren't hearing me, start waving and I'll stand a bit closer to the microphone. So congratulations to Ben on being the newest consultant. I'm grateful to Howard for not introducing me as the oldest consultant, although that is probably nearly true as well. We had this debate about 4 months ago in our medical education training session at Helsden with about 50 doctors, I suppose, there, and a scattering of other people, but nearly all doctors. At the beginning of the session, we had the vote twice just to see what happened. At the beginning of the session, 3 doctors said that they thought the diagnosis was a bad thing. After I'd given my presentation and we'd had the debate, at the end of it, exactly 3 of them said that diagnosis was a bad thing. So I didn't change anybody's mind at all. So I'm hoping that you're going to be a slightly more sympathetic audience to that. It was always going to be hard persuading psychiatrists to give up diagnosis, but maybe this will be a slightly more sympathetic setting for me. But before I start on that, let me be clear about one thing. In principle, diagnosis is a good thing. I'm not in principle opposed to this. If somebody goes to the doctor, if somebody has a headache, working out whether that's a migraine or whether that's meningitis is important. Absolutely important. It's a matter of life and death important to get that sort of thing right. But the important part of that diagnosis is the distinction between meningitis and migraine. And unfortunately, in the sort of the equivalent situation in psychiatry, we're still at the stage of saying that the diagnosis is headache. And that isn't useful in the same sort of way. It just isn't. In medicine, diagnosis changed fundamentally in the 19th century, early 20th century. The germ theory of disease, better understanding of physiology, developing pharmacology, all of that meant that diagnosis genuinely reflected what was wrong with people. It was genuinely based on the pathology, on the problems that people had. In medicine, diagnosis became much more useful when we started to understand the causes and the way in which different illnesses developed. Psychiatry isn't at that stage yet. We're still at the stage of having descriptive diagnosis, not explanatory diagnosis. A diagnosis that describes what we see but doesn't actually tell us what's going on. So the diagnosis that we use remained pretty much artificial. I doubt that any psychiatrist really believes that everybody who's got a diagnosis of schizophrenia has got exactly the same illness, or that nobody else has got a similar sort of problem. Almost certainly, schizophrenia includes several different conditions which share some features but not others, and certainly some, probably even all, of those overlap with other conditions that we give different labels, but may actually be the same. We're in the position of doctors back in the 18th century who classified things, lumped things together by symptoms, not by causes. And without knowing the causes, we're like the story of the blind men with an elephant, all seeing different aspects of the same thing, none of us knowing that we're actually looking at the same thing. Does anybody here believe that there are exactly 22 different types of depression? Okay. I asked the same question at Helsden, and I can tell you none of the psychiatrists believe that there are exactly 22 types of depression either, which is probably good news. But it's odd, because there are exactly 22 distinct categories within ICD-10 of depression. If each of those is a valid diagnosis, and if between them they cover the whole range of possible disorders, then 22 different types of depression with 22 different causes and 22 different treatments and 22 different outcomes is precisely what we should all believe in. And the fact that we don't believe in that just shows, I think, that the diagnosis that we apply to people doesn't have that credibility. In fact, we often say that a lot of people who have symptoms of depression don't have a depressive disorder at all. Lots of people with a diagnosis of schizophrenia have low mood, but we don't change the diagnosis. Unless, of course, we decide that it's not schizophrenia or depression, but it's actually schizoaffective disorder. And what does that mean? Does that mean that there's actually a third sort of illness that's totally different to the other two? Or does it mean that it's one or the other, but we're not quite sure which? Or does it mean that they have both disorders at the same time? I don't know. I don't think anybody really knows. I think what it really means is that neither schizophrenia nor depressive disorder have any real core validity, that they're not actually the thing we're looking at. And that when the going gets tough, we're going to cop out of that tough decision and invent a new label that will take the place of the first two. In medicine, we know that diabetes and asthma are two different things. We don't have to have a category like wheezy diabetic to try and explain how people can have both at the same time. In psychiatry, we can't do that yet. And that's schizophrenia. For all the problems, compared to most other psychiatric diagnoses, that's actually fairly clear-cut. We're actually fairly sure what we're looking at and what we're labelling when we talk about schizophrenia. Get into mood disorders or anxiety states, and the distinction between different conditions become even less clear. Most people with a diagnosis of anxiety have symptoms of low mood. Most people with a diagnosis of depression have some symptoms of anxiety. Are they different? Are they the same? Who really knows? Don't even get me started on the issue of personality disorders and the way we try and diagnose those. And that's to say nothing of the distinction between mental disorders and normal variation. Who really knows at what point low mood or anxiety or obsessionality stops being the normal range of human experience and starts becoming a disorder? We cheerfully attach diagnoses to these things when not only are we not really sure what's wrong with somebody, we're not even sure whether anything's wrong at all. So it's no wonder that the diagnoses we come up with have little face validity. But I don't just want to persuade you today that psychiatric diagnosis is a bit vague and woolly, because you probably all agree with that. I actually want to say that it's a bad thing, that it actually does harm giving people these diagnoses. So, to think about that, what do we think diagnosis is for? Well, I think there are four things that we do with, four reasons why we give people diagnoses. The first, probably the most obvious, the most important, is to suggest appropriate treatment. That's why, back at the beginning, we needed to know the difference between meningitis and migraine, to give the right treatment. But diagnosis in psychiatry doesn't work like that. It's not much use as a guide to treatment in psychiatry. Hardly any of the treatments we give are specific to a particular diagnosis. We use terms like antipsychotic and antidepressant, but we know that's actually of little use when it comes to defining what the drugs do or what we use them for. We use antipsychotics as sedatives. We use anticonvulsants as mood stabilizers. We use antidepressants for pretty much everything. So diagnosis doesn't really guide treatment in the same way. But it's worse because despite that, you can see, particularly in America, how diagnosis in the form of what they use, DSM, which is their equivalent of ICD-10, is used by insurance companies to define exactly what treatments people are allowed to have, what treatments doctors are allowed to prescribe for people, and more importantly, to define what treatments can't be given, and what people can't be patients at all, what people are excluded from services. And we're starting to see exactly the same thing happening here. NICE guidelines are becoming more and more prescriptive, more and more narrowed down, and we have less and less freedom to use any sort of clinical judgment to fit the treatments we give to the needs of the patient in front of us. Some antipsychotics are licensed for use in affective disorders. Some aren't. It's not really about which ones work better, it's not really down to whether they're effective or not. It's basically down to whether or not the drug company thought there'd be money to be made from obtaining a license and going through the regulatory procedure for a particular drug or not. But because the patient has the wrong diagnosis, some treatments we can use, some we can't. Ultimately, this becomes like a sort of cookbook medicine. It de-skills psychiatrists, it makes for mindless treatment. Patient has a diagnosis A, the NICE guidelines force us to give treatment B, and there's no sort of judgment or individuality or understanding in that. And the final stage seems to be payment by results and clustering. You may or may not have heard of this. This is the sort of administrative sort of underpinning of a lot of health services, not just mental health services now. All of psychopathology, all of human experience summed up in half a dozen clusters, and every patient, every person in that cluster expected to receive the same treatment and respond in the same way. That's certainly not how I was brought up to practice psychiatry, and not the way I want to work with patients. But underlying all of that is the belief that the diagnosis is reflecting some sort of underlying reality. The whole rationale for classification has been turned on its head. It started from the premise that we know what mental disorders are, and it would be helpful to have some way of dividing those up, of classifying them to see better what's going on. Now I hear doctors, other professionals, even lawyers, even psychiatrists, taking the view that only if something's in the book, only if something's in ICD, can it be a disorder, and that everything that is in the book is by definition a disorder. Far from helping us to understand the problems we're trying to address, it's used as a straitjacket to limit and restrict what we're allowed to do at all. That's not what it was for. So that's the first thing, treatment. Secondly, it said that even though we don't have great understanding of what's happening in psychiatric disorders, we need some form of classification so that we can carry out research that will lead to better understanding and better classifications in future. But that's only true, that only works if the classification you've got genuinely does separate things into the right groups to start with. For 2,000 years, medicine diagnosed people according to the humoral theories. People had too much blood or too little blood, too much or too little phlegm, and because of that they were diagnosed, they were categorised as being sanguine or phlegmatic accordingly. Nobody working in that mindset was ever going to discover the organism that caused tuberculosis, because they weren't looking for that, they weren't thinking about that. But along the way they could cause plenty of harm by bleeding people and purging people and giving the treatments that their diagnosis led them to. Similarly in psychiatry, if we lump all of schizophrenia together and all of bipolar disorder into a different group, the chances of finding out what's really going on aren't improved, they're actually reduced. Any potential finding, any potential understanding we might have about a group of people within that is going to be drowned out by all the other subgroups. And similarly, the genuine links between patients will get missed because they're allocated into the wrong groups to start with. Effective diagnosis means giving things their right names. But if you don't know the names, if you don't even know which things belong together and which things don't, then rather than guessing, rather than making something up, it's better to recognise that from the start, not to make up a classification that's almost bound to be wrong. Thirdly, diagnosis is used to define what psychiatry is, what our business is and what it isn't. And that's a process that's had profound and negative consequences for our patients and for our profession. The public perception of psychiatry is that we're a pseudoscience, that we use technical sounding jargon to conceal the fact that we don't know what we're doing and there's no real content to what we do. So do the diagnoses that we use, does that give us more credibility or less? Well, a few years ago, visceroptosis was a mainstream psychiatric illness. I don't know if anybody here suffers from that, but a few years ago, people certainly did. A few years before that, thousands of people, mostly women, were suffering from chlorosis. Don't see that anymore either. So thankfully, like things like smallpox, these terrible illnesses have been completely eradicated, no doubt due to the huge advances in psychiatry over the years. I'm sure the Nobel Prize is on its way to somebody for conquering these illnesses. The truth is, I'm sure they described people with problems, but they weren't valid diagnoses. They weren't illnesses, and they're not valid now, and the things we use now aren't valid either. We set ourselves up for ridicule when we change the diagnosis every few years. The American Psychiatric Association spent 15 years debating whether or not homosexuality should be included as a diagnosis. When we can't seem to agree even amongst ourselves on the most basic features of some of these disorders, it's no wonder that the public don't have much trust in us either. And that not only hurts us as a profession, which I do sort of care about, but it contributes to the marginalisation of mental health as being not real illness, and the stigmatisation of our patients as not really ill. Because again, don't let me mislead you, make no mistake, I'm not opposed to diagnosis because I don't believe people really have illnesses or really have genuine problems. I believe that people are genuinely disordered. I'm absolutely sure that there are real disorders and real problems underlying mental illnesses. But too often people fall between the cracks in the system, failing to get the help they need, not because they don't have problems, but because they don't fit into this arbitrary classification that we have. We pathologise some people who would be better left alone, and we exclude others that we could help because they don't fit in, and meanwhile, mental health gets marginalised and trivialised. And that's not just it's not just the public who reject our attempts at classifications. My patients routinely tell me that their experience of their problems don't fit the labels that are applied to them. We're all inclined to call that lack of insight. That's what psychiatrists use to get around that. But the truth is that if the patients themselves can't relate to the problems that we say they've got, we should be looking at that a bit more closely. And then, finally, diagnosis is used for communication. Communication between professionals, communication between agencies, most important, communication with patients, with carers, and with their families. But communication depends on clarity. It depends on saying what you mean and meaning what you say. And it depends on the person on the other end understanding the same thing by what you're saying that you do. Confusing labels become a barrier to communication, not a tool for it. Often I've been in a position talking with patients who are confused and worried, not just because of their disorder, but because of the labels they've been given. They say they've been given different labels by different people. What's really wrong with me, they ask. Was the last guy wrong? Or are you wrong because he was right? The answer, nearly always, is that neither of us was right or wrong. We were both describing what we saw. I say it's greeny blue, you say it's bluey green, so what colour is it really? Who's right and who's wrong? The point is it doesn't matter. But the confusion between that causes distress, causes confusion. It's one more barrier between us and the people that we're trying to help. A good example of that, a few years ago now, I was involved in as a witness, I hasten to say, it was a court case, illustrated a lot of these problems. There ended up with 4 psychiatrists giving evidence in this case. Each of us, under oath, came up with a different diagnosis. It's no wonder that the lawyers and the public make fun of us as not knowing what we're doing. The reality was different. The reality was that we all agreed. We agreed on what was wrong with this guy. We agreed on what should be done about it. We agreed on what effect it had on his responsibility for the crime that he'd committed. We agreed about what caused the problems and how severe they were and when they started. We agreed about what was likely to happen to them in the future. We agreed about what treatment he needed. We didn't disagree about anything important except the diagnosis. And I think that just shows how unimportant the diagnosis actually was. Not just unimportant clinically, but it was actually positively obstructive as a way of communicating information to the rest of the world. So what's the alternative? If we give up hundreds of years of classification and diagnosis of medical tradition, what would take its place? Well, I don't believe that the core skill of psychiatrists is diagnosis. I think the core skill of psychiatrists is understanding. Understanding people from different perspectives, understanding people in their own lives and in their own environments. That's what the biopsychosocial model is all about. Understanding people as individuals, not as examples of a standardised condition. Making sense of where their problems come from and how that interacts with the rest of their lives. If we get away from diagnosis, this is what we've always called, as a profession, psychiatrists have always called formulation. Descriptive, individualised understanding of another person's situation. So, 2 possibilities. Which of these is more useful? Which tells us more? This is a 30-year-old woman with attachment problems stemming from difficult early experiences who functioned well until the death of her mother, since when she's experienced low mood, social anxiety and transient suicidal thoughts. I'm making this up, obviously. Or F32.10, just so we're clear, moderate depressive episode without somatic symptoms. Which of those would tell you more about the person? Which of it would give more understanding about the problems? A better idea of what sort of things might help, or identifies the risks and the potential outcomes? Which leaves us some flexibility to give individual treatment that this person needs? Which has more credibility in the eyes of the patient or her family or the wider public? I think it's a no-brainer. 2 or 3 sentences of formulation tells us more and are much more useful than any sort of diagnosis. And it doesn't pretend that we've got some sort of arcane knowledge that we don't really possess. We don't pretend that we know what's driving, what the causation of those problems are. Even for somebody doing research, you're more likely to identify real similarities, real differences between patients by doing that than by fitting them into a classification. So, diagnosis, I put it to you, does do more harm than good. It's harmful to treatment because it forces us into treating people in standardised ways when they don't have standardised problems. It's harmful to research because it divides things up into the wrong groups and it misidentifies different things as being the same and the same things as being different. It's harmful to our profession and to the status of mental health because it has no credibility to the outside world. It's harmful to our relationships with patients because it prevents us from engaging with the issues they really care about. And it's harmful to services because it allows society to marginalise mental health problems as not being real problems, and because it forces us into disagreements that don't really exist. So that's my proposal. More understanding, less classification. We can do better research, give better treatment, improve our public image, and improve things for our patients. All we have to do is ditch the diagnosis. Thank you.
Okay, so first of all, the whole concept of how we deal with diagnosis. You've already heard what Dr. Jones has said, and I'm going to agree with him to a degree here. This is a fairly detailed anatomical drawing of the heart. There's just, you don't need to count them. There's 38 little kind of labels there on that, and you could probably do another one from the other way round. Just to make about kind of 70 things that if you were a good cardiologist, you'd need to learn. And that's about it. I'm sure cardiologists would argue that, well, we're a bit more complicated than that, but they're not. It's really just pipes and tubes. This is a relatively undetailed picture of the brain. There are, as you can see, lots of different kind of aims, lots of different kind of bits of it. There's the blood vessels up the top. There's the lobes over here. There's the makeup of the individual cells here. I hope you get the idea. It's a bit more of a complicated organ, and so first of all, that's what we're dealing with. And then, secondly to that, is the fact that I don't believe, as a psychiatrist, that I treat the brain. You may recognise this as a kind of as a representation of the biopsychosocial model. Much what I believe that as psychiatrists we treat. So my job is far more complicated than simply saying which particular tube this bit of blood isn't flowing through properly. I have to work on a part of the body that we don't understand very well, and then actually, strictly speaking, treat an organ that doesn't exist, the mind. I'm sure it does exist, but we can't take a picture of it, we can't look at it, we can see things changing in brains, but that doesn't really tell us anything about what we're doing. And that makes it very difficult to come up with nice, straightforward diagnoses. I'm a picture of the heart. I can say, well, this bit's not getting any blood. Look, I've done a scan and there's no blood going through, and there you go. Now the muscle dies. Whereas, even if I show you exactly in the brain where something's going wrong, I still can't necessarily tell you why that's causing the particular symptoms it is. We're getting better at that a little bit, but we're still very much in the kind of early stages of that. So we have to think about how we actually make our diagnoses. And in short, how we make our diagnoses is by a bunch of people sitting around, lots of very important people, I'm sure, but they all sit around and they tell us what they think our diagnosis is formed. That's how our classification systems are formed in psychiatry. It's a group of learned experts who all come together and agree what the symptoms are of the disorders that we're going to be looking at. Which, as Dr. Jones rightly pointed out, is kind of how the rest of medicine was doing it a couple of hundred years ago. The thing is that, yes, there were things that medicine did a couple of hundred years ago that weren't very helpful, but actually there also were good things that happened. People still went to see their doctor, they still had kind of certain treatments, sometimes it was leeches, yes, but actually we use leeches occasionally in modern medicine today, and we still use similar techniques for certain conditions. The problem is that what we have kind of these days is we've reached kind of international consensuses about what makes up certain disorders, and we come up with these kind of big lists of symptoms. If you've got this thing and this thing and this thing, then you've got depression. If you've got this thing and this thing and this thing, then you've got schizophrenia, and so forth. And yes, absolutely, it is all very descriptive. But it's describing things that are seen. We're not necessarily claiming that all of the things that one person experiences are exactly the same as something that somebody else experiences. It's a well-recognized phenomenon that, for instance, with psychosis, the type of symptoms, the type of things that people may believe on one hand, in one part of the world, might be quite different to that in another part of the world. And of course, there is always the argument that what's really happening, as Dr. Jones alluded to, is there's a group of people out there who are trying to make a bit of money out of the fact that they can sell a drug to treat this particular condition. So, our diagnoses are not perfectly set in stone. They're agreed by consensus by a lot of people. Our diagnoses do not have nice, helpful blood tests that prove what they are. Diabetes, Dr. Jones mentioned, a known medical condition, clearly set out guidelines about how to diagnose diabetes, right? Is defined the same way. Everybody has a blood sugar. Everybody's blood sugar fluctuates. An international consensus has agreed that above a certain level of fluctuation you have diabetes. And that's based on what problems people are likely to suffer if they notice that their blood sugar, if they're the kind of people whose blood sugars go above or below a certain level. So it's a recognition that there's a spectrum of normality, and out with that, it can cause problems. And I think to a large degree, that's exactly the same as how psychiatric diagnoses are made too, or how psychiatric classifications are made. The only difference being is that we don't have the nice blood test to say, oh look, your blood sugar's 9, so you've probably got diabetes there. But with all these things, why do we bother? Why do we actually bother making psychiatric diagnosis in the first place? You've already heard why we shouldn't. So hopefully I'm going to tell you why maybe we still should. Good psychiatric practice involves providing the best level of clinical care that is commensurate with training, experience, and the resources available. It involves the ability to formulate a diagnosis and management plan based on often complex evidence from a variety of sources. In making the diagnosis and differential diagnosis, a psychiatrist should use a widely accepted diagnostic system. That's basically what the Royal College of Psychiatrists say is good psychiatric care. I'm going to highlight the first word, royal. That basically means the Queen says we have to. So, unless you want to start committing treason, you've still got to have your diagnosis. Honest. One of the next reasons is because it does guide treatment. Dr. Jones has already sort of talked a bit about the negatives of this, but there are clear guidelines NICE for numerous psychiatric conditions, and where that can be quite a rigid structure to work in. What it also does is it ensures treatment should be available. The whole purpose of producing guidelines by NICE in order to recommend treatment is that actually if you do have that condition, then you should not be barred from having that treatment, essentially. That's what the NICE guidelines are for, to make sure that people get the appropriate treatment for the conditions that they have. Research itself is often focused on specific disorders. And actually, there is, one of the things that's coming from research is groups researching genetic links in schizophrenia and genetic links in bipolar disorder have discovered that actually there seems to be a bit of a crossover, which has inspired debate in recent years in psychiatry about how different these two conditions are. But actually, without that kind of research focus, I think it would have been more difficult to find out those things. If people were just saying, well, we want to research anybody that rocks up at a psychiatric hospital, and we're just going to take their blood and see what happens, I think it would have been much more difficult to actually get those kind of studies happening. So, in a way, I'm kind of arguing against myself, because I'm proving that actually the diagnoses can be a bit fluid between each other, but I think without that system there, we wouldn't have got to where we are now. There is the case that not completely dissimilar treatments in psychiatry, or not completely dissimilar conditions in psychiatry, do have significantly different treatments. There are certain instances where one might not want to use an antidepressant initially in somebody who appears a little low in mood, particularly somebody who is prone to manic episodes, for instance, in bipolar disorder. That can at times lead people to not get treatment that they should have. They don't get antidepressants because people are worried about making them manic. But over the time, what's happened is we've developed a way in which actually we can do that. We make sure that we're not leaving people depressed by making sure they've also got some other treatment to stop the manic relapses. The other danger is that treating in a symptom-only fashion risks missing important illness elsewhere. Now, I wouldn't necessarily accuse Dr. Jones of this, or indeed any of my most competent colleagues. I'm the newest one, remember. But if we simply say, well, your mood appears to be low, you seem to lack energy, and we go ahead and treat you with an antidepressant, do we risk missing your thyroid problem? Do we risk missing the problem you have with your adrenal glands or something? Because we're just trying to make the symptoms better. Now, as I say, hopefully, good doctors will avoid doing that, because you'll have a kind of full workup of somebody, and you will be able to make the diagnosis. But again, it's within the diagnosis. It's yes, this is diagnosis, but actually there are other diagnoses that we need to consider. And if we're sort of doing away with thinking about diagnosis, I think it runs the risk of indeed doing that further down the line. Making a psychiatric diagnosis makes sense. There's a degree of expectation. I searched and searched for a lovely research study, to quote you, that says that patients love to hear a diagnosis, and I couldn't find one anywhere. Apparently patients like empathic, thoughtful, forthright, strong doctors who give them as much time as they want. And I couldn't find anything that said, oh, and actually tell them what's wrong with them. But that seems to be because of a kind of thrust in what we're trying to improve in our profession at the moment. I think it's because diagnosis is at the level of, well, that's what they do. I've had numerous patients say, after sitting with them for 45 minutes, an hour, they say, yeah, but that's fine, doc, but what's actually wrong with me? What's wrong with me? It's not something I always answer. And I do recognise that actually sometimes diagnosis isn't something you go within straight away. But it can provide a degree of relief for people. The diagnoses are created by consensus, yes, but that consensus takes a long time. It took 9 years to produce the ICD-10. It's not something that 5 guys sitting in a room just sort of sit and go, well, I think that's depression. Should we call it? Yeah, that's depression, right? That's schizophrenia, right? Down a boozer. It's not what they do. It's a long and drawn-out process. And what it does is, certainly for some people, it enables them to make sense of their experience. People who have struggled for years with certain aspects of their life, people who have never understood why everybody suddenly hates them for a couple of days, and then they feel really kind of energetic, and everybody gets in their way, and they're not quite sure. They worry about, is this a problem with me? Am I broken? Am I a bad human being? And the diagnosis allows people not an excuse, not an opportunity to say, well, it's not my fault. That's one of the places where a diagnosis can perhaps be a bit harmful, I recognise. But it gives them an explanation which fits with a lot of other people, to recognise that actually, no, this is something that happens. In the same way that your patient with diabetes sees everybody else eating cake and knows that if he eats cake, there's a problem. Until he knows he's got diabetes, he doesn't understand why everybody else eats cake and they seem to be joyous and happy afterwards. And he feels rotten. Now, I'm not going to argue that the diagnostic system is perfect. I think Dr. Jones has done that very well for me. It's not close to a perfect system. But it's not just likely to change. It inevitably will change and is changing all the time. Some arguments suggest that it's changing the wrong way, and actually we're making more diagnoses when we should be making less. One of the key things I do in my practice is when I do give people a diagnosis, I very often follow up with the fact that that's not you, though. This is a diagnosis. This is an illness that I believe you suffer. But it's not you. If you have bipolar disorder, that doesn't mean that your life is constantly horribly depressed or exhaustively manic. You can have plenty of time where you're going to be okay. You have a slight proneness to the edges of those moods. But it doesn't define who you are. And in fact, I think one of the really difficult outcomes is when people feel like they can't experience normality. They can't wake up a bit grumpy in the morning without questioning, oh, am I going low? Or, have a particularly enjoyable day and think, oh, am I going high? The whole system is still in its infancy, as I've said. Ultimately, what we've got is a system that describes what we see in front of us, yes. But most conditions start like that. And that doesn't mean they weren't valid then. By having a starting point, we then develop research, we develop more treatments. We understand the conditions better. Over time through research. This is what's happened with countless conditions. One of the most kind of well-known ones of recent times is the change from when it was originally discovered to what HIV and AIDS is now. A very well understood and in Western countries generally considered a chronic illness now because the treatment has got so good. At first was simply a description of symptoms, because we didn't know what it was. There will always be a subjective element. I completely agree. The standard joke is that if you have five psychiatrists in the room, you generally have 6 diagnoses. That's not uncommon. For me, in a way, actually, that can be a good thing sometimes too. It allows debate within the actual profession. It allows people to discuss, you know, what are we getting right and what are we getting wrong. We're the only profession I know who would, certainly within medicine, who would have, as a kind of professor of it, somebody who says that it's all rubbish. And I think I've always liked that about psychiatry. It knows that it's not got it all right. And crucially, my last point about diagnosis is, whatever you think about it, it should never be the whole sentence. I completely agree with the idea of formulation that Dr. Jones has put forward. He's asked about what tells you more. But I encourage you to think of the person going home to their family, having seen the doctor, and the family say, "What did he say?" He said, "Oh, I'm a 30-year-old lady with attachment issues growing up in childhood and some difficulties at school, and I now appear to be experiencing a bit of low mood in the context of some social stresses." What? Or, well, I've got a bit of depression. I completely agree that in terms of actually how we're working, the formulation may indeed be the more helpful thing. But the diagnosis has a place too. It aids communication in a different way. I'm going to quote somebody else to finish, somebody who I don't know who it is. I tried to find out who the quote was and I couldn't. But somebody very wise recently said, "Diagnostic classificatory systems, they're like lines of longitude and latitude. Nothing like them actually exists in the real world. They are very helpful in finding our way around." And that's all I'll say. Thank you.
Please stand if you think diagnosis is a bad thing. I mean, someone can. Oh, now, how many have we got?
It's more than 3, which is what I was saying.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Okay. Now, who thinks diagnosis is a good thing? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22. Lovely. And who thinks we should pause and let the debate continue? 3, 4, 5. Oh, I'll give a bit of time on this one. 3, 4, 5, 6, 7, 8. And 2 standing as well. 10. Thank you. Thank you very much.